Good afternoon, everyone. Greetings from NITRD and a heartfelt welcome to all our esteemed guests and colleagues to the 5th NITRD Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. This clinic aims to disseminate the pediatric TB guidelines and build capacity building of the healthcare providers in managing pediatric TB at the peripheral level. On behalf of NITRD, I extend my warm greetings to our DDZ ma'am. She will be joining us soon. She's traveling, so she may not join, or if possible, she may join us in the later half of the clinic. I welcome directors and team from NIIT, NTIs, STOs, directors of STDCs, faculty of medical colleges, and district TB officers, TB pediatrician, everyone who is present in today's clinic. Let me introduce the faculty from NITRD. I am Dr. Saroj Meena, chest specialist at NITRD, and will be moderating today's session. To my right is Dr. Alok Yadav. He is CMO NFSG at NITRD. He is a pediatrician. To my left is Dr. Dhulika. She's a specialist pediatrician at NITRD. And to my extreme left is Dr. Neeta Singla ma'am, who is Nodal Officer for the conduct of eco clinics at NITRD. Our director is on leave these days, so I'll directly go to Dr. Urvashi ma'am to give her. Good afternoon, Dr. Urvashi.
Good afternoon, all. Like always, I want to congratulate the team NITRD under the leadership of Dr. Neeta Singla, who have consistently organized these difficult to treat clinics and pediatric clinics. And I'm sure the learnings from each of these meetings goes a long way for all the participants to train them to deal with difficult cases. So, with my best wishes for the discussion today, I may not be able to stay with you throughout the session, but I'll try and join as soon as I can. Thank you so much, Dr. Neeta and team. Thanks to Dr. Director NITRD also for the constant effort at all the trainings that NITRD provides. Thanks again.
Thank you, ma'am. And thank you so much. It's quite motivating that you take out time, time from your busy schedule, and especially now when you're waiting for the flight and you feel the importance of the clinic and you address the clinic. That is quite motivating for us. Thank you so much. Now, the pre-test link has been shared in your registered email ID. Please attempt before we move on to the clinic. So today's case is from AIMS Bhopal, Department of Pediatrics. Dr. Ambar Kumar's team will be presenting the case. Dr. Monish Darshan and Dr. Shivangi, junior residents in the Department of Pediatrics, AIMS Bhopal, will be presenting the case. And Dr. Ambar Kumar, who is an associate professor in the Department of Pediatrics, will serve as a case expert for today. The national expert for the day is Professor Dr. Virender Singh, Director Professor in HOD Department of Pediatrics, Lady Harding Medical College and Kalavati Saran Children Hospital, New Delhi. He is also lead National Center of Excellence for Pediatric TB under NTP. Now, moving on to the case, I request Dr. Monish Darshan to kindly start with case presentation. Dr. Monish, over to you.
Yes, ma'am. Good afternoon, all present here. I'm going to we shall go for the case one. A 4-month-old male child from MP had come with the complaints of fever for the past 2.5 months, high grade, documented with no diurnal variation, not associated with chills and rigors, no bleeding manifestations or RATs. Also, child had complaints of abdominal distension for the past 2 months, which was insidious, progressive in nature, involving main.
We can't hear anything. Is it here or at the other end?
Sir, it is at the other end. He's freezed.
Okay.
I think that's some issue.
Good afternoon. Sorry, we had some technical hiccup.
Okay. Good afternoon, sir.
Good afternoon.
Good afternoon. Dr. Amar, are you facing some technical issues, sir? Dr. Amar, can you hear us? You're muted. Please unmute yourself. We cannot hear you. Dr. Monish, can you start from the beginning? Can you hear us, Dr. Monish?
Yes, ma'am. So from the summary of
Start from the first slide again. From the first slide.
Yes, ma'am.
Yes.
Hello.
Please carry on.
A 4-month-old male child from MP had come with complaints of fever for the past 2.5 months, which is high grade, not documented, with no diarrheal variation, not associated with chills and rigors, and no bleeding manifestations or rash associated with the fever. Along with it, the child had complaints of abdominal distension for 2 months, insidious, progressive in nature, especially involving the upper part of the abdomen, not associated with excessive crying or bowel disturbances. Parents also noticed multiple swellings in neck and axilla for the past 2 months, with redness in the left upper arm region.
Dr. Monish, go slowly. You're running actually.
Oh, sorry, ma'am. No history of hospitalization in the past, no history of surgeries or blood transfusion in the past. Child was a full term delivered via normal vaginal delivery at a hospital who cried immediately after birth with birth weight of 2.9 kgs with a smooth perinatal transition. Child also received pentavalent OPV and rotavirus at 14 weeks of age, and BCG scar was present. Child was born via second order consanguineous marriage with no history of similar history in any family members, no history of any family members affected with TB, no history of any recurrent early sibling loss or recurrent abortions. So from the above history, we summarize as a 4-month-old male born out of second consanguineous marriage, fully immunized for age, with no history of TB contact, had presented with high-grade fever spikes, progressive abdominal distension, and multiple swelling in neck and axilla, along with redness over the BCG vaccination site. Anthropometer-wise, child is labeled as severely malnourished. On examination, child was vitally stable, not in a respiratory distress or failure, no circulatory failure. PLR was present, no icterus, no cyanosis, no clubbing. A single non-tender lymph node of size 4 x 4 centimeter was palpable in the left axilla, along with multiple cervical lymph nodes noted, of which left cervical node measuring 2 x 1.5 centimeter and right cervical node measuring 1.5 x 1.5 centimeter in maximum. With it, the image shows the child with the erythema induration noted over the left deltoid region, which is the BCG vaccination site. On systemic examination, abdomen was distended with the palpable organomegaly, which is hepatosplenomegaly, with a liver span of 10.5 centimeter, which is more for the age and gender, and spleen tip palpable at 9 centimeter below costal margin, which according to Hackett's grading comes under the grade 4. Along cardiovascular system is unremarkable. Our respiratory system, bilateral air entry present and equal on both sides noted. CNS wise, child was unremarkable. So this now we'll see the timeline of how the child has presented to our center with the above mentioned complaints. Child actually developed the above mentioned complaints at 1.5 months of age, but the child presented to our center at 4th month of age. Following which, child from the clinical history and the examination findings, child was initially diagnosed as a case of accelerated BCG reaction. But the points against such diagnosis was presence of contralateral lymph nodes along with hepatosplenomegaly. So following which the child was investigated which showed gastric aspirate being unremarkable. AFB CBNAT for gastric aspirate sample being unremarkable, but FNAC of the lymph node showed AFB positivity and CBNAT positivity, but the MGIT culture was sterile. So this is X-ray which is normal in nature, no infiltrate for noted. So from the above clinical presentation and the investigative profile, child was labeled as a case of disseminated BCOsis. So in view of disseminated BCOsis, child was worked up for underlying immunodeficiency, whether being primary or secondary. So mother's HIV status was non-reactive. NBT-DHR was done, which was non-negative, which rules out chronic granulomatous disease. Immunoglobulin levels were normal as well as hyper IgM syndrome. But unsurprisingly, flow cytometry was done in order to look for MSMD changes, which showed STAT1 nil expression in CD14 monocytes, which was later confirmed with exome sequencing, which interferon gamma receptor 2 mutation, which is suggestive of MSMD. So following which, the child was in the lines of doses with HRE and levoflox. HRE regimen with levoflox was in our OPD for the first 2 to 3 months, where 1.5 centimeter cross 1.5 centimeter, which suggests of partial response. But later, child had not turned back to our OPD and was lost to follow up for 8 to 18 months of age. Later, again, child had presented at 18th month of age to our center with recurrence of symptoms such as fever, increase of lymph nodes, abdominal distension, which on examination was hepatosplenomegaly was noted. During this stage, the gastric aspirate was sent, which showed here AFB CBNAT being positive and rifampicin sensitive. So, keeping in mind of MTB complex disease, the child was started on HRZE plus levoflox. During the hospital stay, the child anemia and thrombocytopenia were documented, and in view of high-grade fever spikes with hepatosplenomegaly with bicytopenia, suspicion of HLH, bone marrow was done, which showed 4K of histiocytes collected. CECT abdomen was also done, showing multiple liver parenchyma, which further on biopsy showed chronic inflammatory infiltrates with ill-formed aggregates of histiocytes with fibrosis. Lymph node biopsy was also done, which showed ill-formed epithelioid granuloma with focal neutrophilic infiltrate with plenty of acid-fast bacilli. This image shows the HPF image of the lymph node acid-fast bacilli. Child had a prolonged stay at our center, but was and there was no proper response documented following HRZD levoflox. Hence, in view of suspicion of non-tubercular mycobacterium, blood culture MGIT was done, which later on MALDI-TOF showed mycobacterium abscesses. Following which, 3 more drugs, which was amikacin, clarithromycin, and clofazimine, and this therapy was continued for 1.5 years of duration, in which there was documentation of lymph node regression. Parents were counseled about the bone marrow transplantation therapy for definitive management of MSMD and discharge. But during this hospital stay, child also developed a foie abscess and received meropenem linezolide for 2 months. X-ray was done, but it was documented in file being non-specific infiltrates. Film could not be retrieved from old records. Child also was had admission for cystitis. Later, child was discharged, and after 6 months, it was found that the child succumbed to the underlying illness at home. Can we continue the discussion?
We can take questions from the audience before we go with the discussion. So, any questions on the basis of history? Shall we move on then? So, I have one question regarding the history. Like we were suspecting BC genosis in this patient, despite the clinical picture was not matching because of the presence of the multiple lymph nodes also and multiple system involvement also. So we continued with jet omitted. We replaced it with levoflox. Meanwhile, the patient got, and we were also suspecting for MOD. But CBNet always shows MTB detected, and why we treated for MOD then? We haven't got any treatment. Culture has not grown for MOD. So apart from clinical suspicion, there was any other proof where it was suggestive of MOD? Because even it was done from the lymph node, it was as MTB detected, and usually doesn't. So, Dr. Varinder sir, can
Yeah.
Hello.
Hello.
Yeah.
Yes.
So yes, you have a very valid question. I couldn't see who was asking this question, but it's a very valid question. That if the uh, CBNAT is positive, then it is less likely to be NTM because NTM positivity is very low. Very rare you have smear positivity, you do not have NAT positivity. That's one of the way to differentiate. If you have smear which is positive and NAT is negative, because NAT is much more sensitive, you would consider a possibility of NTM. But one of the things which is also important in this context is that many a time these FNACs come positive by cytology, which is a concentrated specimen. And when you send the lymph node aspirate for CBNAT, you add some saline to dilute it, and they may actually decrease the concentration, and therefore it may be negative, not because all the time it is because of NTM. So we have to keep that in mind. But yes, that's how, if everything else is equal, then smear positive, NAT negative is more likely NTM. Here it was NAD positive throughout, and this child was improving initially. So I think because of the underlying disorder, she should have perhaps required a longer treatment because she does not have any capacity to, no immunity to deal with any intracellular organism. And this mother, for some reason, the patient was lost to follow up, and that is where possibly it increased in number. So Malditoff did show Mycobacterium abscesses. It's a new upcoming technology. Whether this was a second infection to which this child may have been prone, and this comes from a different area where you have not used the same specimen for against CB0, is one possibility, or it may be a red herring. It's harder to say whether it was truly an NTM. One more question, Dr. Ambar, which is important, relevant, is that
Yes.
with BCG, you usually have ipsilateral disease. Okay. So if you have a contralateral disease, then you think of a disseminated disease. Because if it is high up on the shoulder, then same side cervical nodes can come even without dissemination, because it's a high up given BCG, which happens very often. So the site of BCG is very important in your patient. If the cervical nodes were there, and what I remember from the picture which you showed, the site was not too high up. So that makes one clue that it may be disseminated. The other is that the contralateral nodes were also involved. However, remember, if your FNAC is not from the contralateral side, you cannot assume that those lymph nodes were because of dissemination. So you must have done the aspiration from the contralateral side also, which is important. So
Yes.
to say it is disseminated lymphatic dissemination, though later on this child had, the course of the illness suggests that there was dissemination, there was abdominal distension, there was abdominal nodes, etc. But largely to clinch the diagnosis of disseminated BCGosis. So because this is a general audience, so this general audience is something where it is more important is not the rare diagnosis, is to when to think of this lymph node from BCG is not just a BCG reaction which nothing needs to be done for. Because if you have a normal child with BCG reaction and a lymph node, it will be CBNAT positive, it will be smear positive, but nothing needs to be done. However, if you have either clinical signs, systemic signs to suggest dissemination, hepatosplenomegaly, or you have distant areas which get involved, like a contralateral site getting in lymphadenopathy, which is also because of Mycobacterium tuberculosis, then only we can say it is a disseminated BCGosis, because it's a temporally related thing. In an older child, it will be harder to say. They could have got a routine MTB infection, but here's a 4-month-old child who became symptomatic about 6 weeks of life or 8 weeks of life, and therefore possibility of this temporally being related and disseminated makes disseminated BCGosis a possibility. So these are the quick comments I have.
Yeah, sir. Thank you, sir. Yeah, one point we did only ipsilateral lymph node aspiration, and the contralateral we did not perform. Actually, this was the point well taken, sir. And the other point also, sir, we absolutely agree with your point, sir. Because of contralateral involvement, we thought of disseminated BCGosis in this case. And the FNAC was CB net positive. So CB net positive only in case of MTV complex, like Mycobacterium tuberculosis or Mycobacterium bovis. And NTM is unlikely to be CB net positive. So NTM has been ruled out based on CB net positivity. And that's why we thought of more of disseminated basidiosis based on the clinical symptoms, contralateral lymph node involvement, and hepatosplenomegaly. So based on this symptom, we have started HRE plus levoflox in this case. And child responded well initially. But we wanted to prolong this treatment, but he could not follow up with our center. And then he came again at 18 months. So that was the lacunae in this case. And at 18 months, he again came with the all flared up of all the symptoms. And this time, the NTM was grown in this case. So this is because this is probably the separate infection that has been grown in this case. But this time, again, gastric aspirate was positive. So now here there was a confusion whether it's a MTV, whether it's a disseminated basidiosis, and as well as NTM. So it's a mixed picture of all the three in this case. So that was the confusion. That's why we have started with the 7-drug treatment in this case. So that was the challenge in this case, how to balance with the number of drugs and with the proper clinical response. So that was the challenge we faced in this case, sir.
So GA positive could be part of the dissemination itself. So you don't have to think of 3 diseases. It could still be BCG. There is no way you can differentiate unless until you have a culture, and on the culture you are able to run some tests like niacin or others to say whether it is BCG or not. It's harder. Or the other answer is from the WGS for knowing whether it's a BCG strain or not. With respect to the NTM, well, I would say the case is still open. It is not conclusive that there was another, whether Malditov abscesses was definitely right. But given the background illness, which is very severe and almost lethal, because here it is just not the therapy which is important. One has to actually think of a hematopoietic stem cell transplant or some other specific therapy, because this individual, if has a partial deficiency, there is some chance. Then you can give interferon gamma, or there may be some possibility. Otherwise, it's a lethal disease. Not many survive, and because it's not only that they would be prone to TB bacilli, they'll be prone to any intracellular bacilli. So it could be nocardia, it could be even something like a salmonella, which stays, and they often would have complications because of these. So giving them just tubercular therapy, and that too for 6 months, is not recommended, because there is no immunity playing any role here. One needs to work differently in these situations. So that's all from my end. But very interesting case. Maybe in the interest of time, because I realize we have one more case, we can continue.
Yes, sir. Thank you so much. So we can continue with the discussion, Dr. Amber.
Yeah, this is short discussion, and then we'll go for second case.
Yes, sir.
So MSMD, we'll be discussing about MSMD, which is Mendelian susceptibility to mycobacterial diseases. It is a rare form of inborn error of immunity, which is basically a defect in the innate and intrinsic immunity, which predisposes the child to weakly virulent mycobacteria, such as BCG vaccine bacteria or non-tubercular mycobacteria, which is environmental mycobacterium. Infection due to more virulent mycobacterial tuberculosis is also noted. It ranges from localized to disseminated or persistent life-threatening infections. So this is the mechanism by which the macrophage helps in killing the mycobacteria, where the macrophage, after engulfing the mycobacteria, it produces interleukin 12, which acts on the interleukin 12 receptor, which is also a co-receptor for interleukin 23, which is present on the surface of T cell. So on activation of the IL-12 receptor, the T cell produces interferon gamma, which acts on the interferon gamma receptor on the surface of macrophage, which helps in killing the mycobacteria. If there's a defect in the IL-20, 12 and 23 co-receptor, or if there's a defect in the interferon gamma receptor, or if there's a defect in the signaling receptor pathways down regulating below the receptors, it leads to MSMD. This tabular column shows the 3 most common mutations which leads to MSMD.
Dr. Amber, can you
IL-12 receptor beta 1 deficiency. So this is presentation of with M1S BCG.
Dr. Amber,
Yes, ma'am.
if you can,
Yes, ma'am. Yes, sir.
maybe you can switch off your video because your internet bandwidth seems to be not
Yeah.
optimal. So we are losing your voice in between, and go back quickly to the table and explain that. Just the quick salient points. Thank you.
So these are the three types of mutations seen in MSMD, of which most common is IL-12 receptor beta 1, which is basically defective signaling of interleukin 12 and 23. It most commonly presents with mycobacterial diseases, salmonella infection, and chronic mucocutaneous candidiasis. The other one is interferon gamma receptor deficiency, which leads to disseminated BCGosis and/or environmental mycobacteria with poorly characterized granulomas. The other one is STAT1 deficiency, which leads to impaired response to interferon in macrophages, leading to more susceptibility to mycobacterium and viral diseases. This is an image representation of a child with MSMD showing various manifestations, of which the most common are BCG adenitis, multifocal osteomyelitis, and chronic mucocutaneous candidiasis. So we'll be discussing the infectious spectrum of MSMD, of which the most common infection seen in children with MSMD is BCG, which is of two types, which is accelerated BCG reaction, which is also known as BCGitis, which presents as a local abscess, severe ulcer at injection site, or involvement of ipsilateral lymph nodes with suppuration and fistula formation. The other form is BCGosis, which is a life-threatening dissemination of infection involving major organs such as liver, lungs, bones, spleen, and CNS. 35 to 100 patients with MSMD manifest initially with the BCG complications, of which 80 to 40% with adenitis and 25 to 85% with BCGosis. So the above figures actually signify the importance of screening of MSMD in patients with BCG complications post-vaccination. Because early screening helps not only to reduce the delay in diagnosis, but also helps to reduce the morbidity and mortality in MSMD children. BCG vaccination can be delayed in patients with strong family history of sibling death due to BCG complications and must be investigated. Hence, this signifies the importance of proper family history to be taken in patients with MSMD. The challenges in diagnosis of MSMD is due to lack of awareness of non-tubercular mycobacterial diseases, poor or inadequate diagnostic methods, and clinical symptoms of NTM being similar to that of MTB. Hence, they are most commonly misdiagnosed as drug-resistant MTB. Similar to our case, in which we had a confusion between Mycobacterium tuberculosis with BCGosis and NTM being Mycobacterium abscesses present in our case study. The decision to treat is also made without confirmation of the mycobacterial species, hence leading to increased chances of drug resistance. And molecular methods such as CBNAT, RUNAT, which targets only mycobacterial tuberculosis complex, hence it will miss the diagnosis of non-tubercular mycobacterium. Hence, there's a need for specific probes. But the gold standard for diagnosis of NTM is culture. But the disadvantage in culture is there are slow-growing NTMs which require long turnaround time. But in our case, since it is Mycobacterium abscesses, we got the culture within 7 days of submission of sample. So in recent years, multitude of MS-based systems have been available for rapid and accurate identification of most clinically relevant mycobacterium, since it has the advantage of both accuracy and rapid turnaround time compared to phenotype-based culture tests. Now coming to management of BCG is difficult since there's no evidence-based guidelines available for proper selection of antimicrobial regimens. So hence the treatment is currently based upon case-by-case criteria. So BCG inherently is resistant to parenzyramide, hence not included in the treatment. The course for treatment of BCGosis is modified ATT, which is of a prolonged course, nearly for including 9 to 12 months of duration, sometimes prolonging up to 18 months. Response well with second-line ATTs, especially fluoroquinolones and aminoglycosides, hence early initiation is a must. Once controlled, prophylactic regimen of isoniazid and rifampicin should be continued until immunological reconstitution happens after bone marrow transplantation. At the end of therapy, biannual follow-up for at least 2 years is mandatory, and treatment failure here is defined as no response after 5 months of ATT. Once the patient is stabilized, bone marrow transplant is the only curative treatment option in children with MSMD. But overall prognosis is poor, has high recurrence of infection and graft versus host disease in MSMD patients post-transplantation is documented. Now we'll have a small discussion on Mycobacterial abscesses, which is a rapidly growing mycobacterium. According to Runyan's classification, comes under class 4, having high level of in vitro resistance to many antibiotics. The treatment of Mycobacterial abscesses consists of IV, oral, and inhaled medications, with the outcome being good when there is no macrolide resistance, especially the ERM gene is not functional. Most recurrences appear due to reinfection or infection secondary to another species. So the image which is shown in this picture, the balance which needs to be done between over treatment and under treatment is much significance, because being intrinsically resistant to many antibiotics, we must start much more antibiotics, a lot number of antibiotics, which leads to over treatment, which in turn leads to drug toxicity. But if we keep the over treatment in mind and we reduce the amount of antibiotics, then it might also lead to under treatment and both leading to disease progression. Hence, physician treating a mycobacterial abscess, especially non-tubercular mycobacterium, need to have a balance between under treatment and over treatment. This is the diagnostic algorithm of diagnosis of NTM. Since initially AFB and CBNAT, if positive, it is suggestive of MTB complex, and if the CBNAT is negative, it is suggestive of NTM. But it needs to be confirmed by MGIT culture. Once MGIT culture is positive and NTM is confirmed, we have to go on with the species identification with the RNA PCR, and following drug susceptibility testing is mandatory. This is a flowchart showing the treatment of M. abscessus complex. Initially, the treatment regimen is based upon whether there is macrolide resistance or not. If there is no macrolide resistance, then the initiation phase treatment regimen consists of a macrolide along with one or more than one active drug with the IV ampicillin for 2 months of initiation therapy. Followed by which we will be going with the continuation phase for up to 12 months of culture negativity to be documented with macrolide, one or more active drug with inhaled amikacin in order to reduce the toxicity of IV amikacin. If the macrolide resistance is documented, then we'll go with the initiation phase of 2 months with 2 or more active drugs with the IV amikacin for 2 months, followed by the same regimen replacing IV amikacin with inhaled amikacin. And the role of macrolide is uncertain, but it helps in immunomodulator properties. Thank you.
Thank you. Do we have any questions of it? I think we can move on to the second case. Yes, Dr. Lo. Dr.
Very nice case presentation by Dr. Amber and Sir and his team. Basically, these are the cases which we are not pick up in our routine OPDs, and these are the cases which we have to think out of the boxes. Only my question is this: initially the gastric aspirate was found negative, and at the end of 18 months, when the gastric aspirate was done, it was found positive. So at that time, is any culture was done to find out the sensitivity of isoniazid or also? And is this the gastric aspirate which was found at the end of 18 months positive, it was due to the dissemination or it is due to the new infection? My first question is this. And if we omit the levofloxacin in view of the mycobacterium, in view of thinking that this is due to Mycobacterium bovis, then at the end of 18 months when it was found positive, it may be Mycobacterium also due to TB. So can we add at this stage pyrazinamide at this stage also?
Yeah, yes, sir. First time MGIT, first time gastric aspirate was negative, and that's why we are thinking of disseminated basidiosis. Second time gastric aspirate was positive, but MGIT culture was negative from the gastric aspirate sample. But the blood culture showed Mycobacterium abscesses, and the subsequent culture on MGIT that has grown Mycobacterium abscesses. And this time, because the gastric aspirate was positive, that was our confusion also, whether this is Mycobacterium tuberculosis or it's a dissemination. So probably it was a dissemination, but we have started pyrazinamide again. In this phase, we have added the pyrazinamide at the 18 month second event. Pyrazinamide with levofloxacin we have continued in the second phase.
Thank you, sir.
Second MGIT positivity,
Yes, sir.
was on what specimen?
Sir, second was on blood culture positive in Mycobacterium abscesses, and subsequently it was cultured on MGIT, and then Malditov was applied, sir.
On the blood?
Blood, yes, sir.
Okay. Thank you, sir. We can move on to the second case.
Good afternoon, everyone. I'll be presenting the case of a 4-month-old male infant resident of Madhya Pradesh presented to who was firstborn of non-consanguineous marriage, full-term vaginal delivery with no history of any NICU stay, presented with the complaints of fast breathing noticed by the mother since 1 week of age, which was insidious in onset and aggravated for last 1 month. It was not associated with any successive cycle, not associated with any bluish discoloration of lips or mucosa, or any history suggestive of feeding diaphoresis. The mother also noticed child having cough since 15 days of life, which was non-productive and not associated with any post-acid vomiting. For the last 20 days, the child was having fever, which was documented as 100.6 degree Fahrenheit, intermittent and relieved on taking medication. For all of these complaints, the mother has sought treatment since 3.5 months of age, and the child was admitted in multiple outside hospitals and had received IV antibiotics. The family history was significant in the form that mother is a known case of clinical low radiological diagnosed pulmonary TB on anti-tubercular treatment since April 24. At that time, the age of the child was 15 days. Immunization history, the child was immunized till 10 weeks of life as per national immunization schedule, and BCG scar was present. When the child presented to us in a pediatric emergency, the general appearance was the child was active and alert. Vitally, the child has sinus tachycardia, and signs of respiratory distress in the form of retractions and tachypnea was present. And SpO saturation was also 90% on room air, which had improved to 98% when we on bubble CPAP. In anthropometry, while the weight for age was less than -3 standard deviation, and length was also at -3 standard deviation, and weight for length was less than -3 standard deviation, which was lying in severe malnutrition according to WHO growth standards 2006. In general physical examination, there were no pallor, clubbing, cyanosis, or any significant lymphadenopathy in the patient. The BCG scar was present in left upper arm, and no obvious dysmorphism as noted. In systemic examination, on respiratory system examination, the tachypnea was present with bilateral air entry present, and bilateral coarse creps were heard in inframammary and infraaxillary area. Abdominal examination, it was soft distended, with liver was palpable 3 centimeter below right subcostal margin with span of 5.5 centimeter, which was normal for the age, and spleen was palpated 2 centimeter along longitudinal axis. CNS and CV system were normal. No abnormality was detected. After the clinical examination and history, the first primary system that we thought was involved in this patient was respiratory symptoms, and with the history of pulmonary TB in the mother, on active pulmonary TB in the mother, we had thought infective etiology, primarily tuberculosis. Now the challenge was whether it was congenital tuberculosis or postnatally acquired tuberculosis. The fallacy that was there in this patient was the child was not screened at the time of mother's diagnosis. The mother was started on anti-tubercular treatment at 15 when the child was 15 days old, and there were no history as told by the mother that the child was screened for active tuberculosis. The history of the mother was mother was symptomatic since January 24 when she was 7 months pregnant, with symptoms of cough and fever present in the mother. And after the birth of the child, according to the mother, the child was symptomatic since 7th day of life. And even after when the mother was diagnosed with pulmonary tuberculosis, there was no screening done for this child in outside hospitals, which led to the further spread of the disease and complications that we will see further. When we planned the workup for this patient, the X-ray was done. In this X-ray, it is anterior-posterior view with adequate exposure, but it is a rotated film. Not very conclusive, but that the things that we could see was there was left lower lung opacities, heterogeneous opacities were noted. In view of significant family history and early onset of symptoms, we had done GA-CBNAT in the patient. The first GA-CBNAT that we did was negative. Since we could not get a microbiological confirmation in this patient, so we had simultaneously planned CCD thorax for this patient and one more GA-CBNAT we had sent. The CCD thorax revealed multiple discrete subcentimetric centrilobular nodules with tree-invert pattern noted in bilateral lungs, which was suggestive of endobronchial spread. Along with that, the gastric aspirate CBNAT was positive for the patient. MTB complex was detected, which was sensitive for rifampicin. After this is the report that we had received. This is the CECT of the patient. In this, we can see multiple tree-invert appearance and the consolidation in which was present bilaterally in right lung and left lung also. And along with that, there were atelectasis and hyperinflation in the left lung that we can see in CT film. Now, for the diagnosis, we had considered this patient primarily treated and diagnosed this patient as congenital tuberculosis only because the symptoms of the patient, symptoms in the mother was present before before the birth of the baby, 7 months of age, pregnancy only. Along with that, we could not completely rule out this was thing. And after that, the child had symptoms within the 7 days of life. So in the modified Cantwell criteria, the child we had proven tuberculosis disease, and along with that, the child had symptoms within newborn, within first week of life. We had not done biopsy in this patient because the diagnostic because the epidemiological significance is this key. There is only epidemiological significance in the differentiation of congenital and postnatal tuberculosis. The treatment that we'll give, that will be same, only the duration of the treatment will change. Such that if it is pulmonary tuberculosis, we'll give treatment for only 6 months. But if it is congenital tuberculosis, we'll give treatment for 6 to 9 months. But that is why we had not gone for liver biopsy in this patient. We had started isoniazid in this patient, rifampicin, pyrazinamide, ethambutol. Along with that, we had also given prednisolone for this patient because of endobronchial spread and atelectasis hyperinflation in this patient. After receiving the 1 month of antitubercular treatment, child had gained weight and symptoms were also decreased, and the child was discharged from our center.
Thank you, Dr. Shivangi. It was a wonderful presentation and a well-chosen case for congenital tuberculosis. And definitely, you have nicely highlighted the lack of screening of the child, which is must in this patient. The mother is symptomatic and has been diagnosed. The child should have been screened for symptoms or for diagnosis of tuberculosis, which was missed in the beginning, but nicely managed. Any questions from the audience? Dr. Amber, can we have your opinion on these cases?
Yeah, this case we have selected only because the congenital TB we have to timely screen the newborn, and timely screening and early detection can prevent the severe illness. Like in this case, because of late detection and rapid progression, endobronchial spread leading to the bilateral lung involvement and atelectasis, hyperinflation, all these severe symptoms, severe pulmonary TB symptoms appeared in this case when we started the treatment. So timely diagnosis, prophylaxis treatment, and all these things are very important for if any mother has diagnosed with pulmonary TB in the pregnancy.
Thank you, sir. Dr. Varinder, sir, can you highlight on the use of steroid in such cases? Like we have used prednisolone in this case, and in pediatric population, what are the indication for use of steroids?
Professor Kamal is going to respond to it.
Good afternoon. Before sir comes, I have
Good afternoon, sir.
Good afternoon. So one question to the treating team: was a lumbar puncture done?
Yes, sir. We had done lumbar puncture. That it was normal. The proteins
Well, I think it did not come up in the presentation.
The presentation by CSF was done.
Sir, CSF was done.
Okay, fine. Because it's a severe disease, and that is one of, and probably measuring of head circumference can be important if suppose that is done. Secondly, if on that radiograph, if you see now, it's not just rotation. Even on it is later confirmed on the CT scan that there is air trapping on the left side. Now there could be a lymph node pressing the left main bronchus here, which is not very well seen on this chest radiograph, but on the CT those images are missing. So probably it's not just rotation alone. If you see the vertebral column, it is almost in the center. So there may be a airway compromise here, which may be better seen on a CT scan. Of course, that will become a reason for starting steroids, other than, of course, if the child has TBM. The second point is that as per the Cantwell criteria, there is no need for us to go for a liver biopsy, I feel, because it's a theoretical exercise whether it is congenital or acquired postnatal, particularly in this child when the symptoms started within 7 days. It doesn't have a therapeutic implication. Ultimately, the treatment will remain the same whether it has been congenital or just after that. And there is a comment was dextrocardia noted. I think it was a dextro version. It's a dextro position. It's a shift to the heart, not dextrocardia. So here in this particular case, I think there should be some mediastinal mass which is pressing the airway, most likely the left main bronchus, which is causing this air trapping on one side and mediastinal shift to the other side.
So if you see carefully on the X-ray, you are able to see cross herniation of the lung in the upper mediastinum. So that itself tells you that this heart is shifted. There is some degree of rotation, agreed, but that is not significant enough. So as Dr. Kamal was also mentioning, CT is showing air trapping in the upper lobe left side, and we are seeing evidence of cross herniation here also. So this is a dextro position of the heart. Heart has been pushed to the contralateral side because of a partial obstruction, most likely because of endobronchial TB. So one of the questions which was asked was whether steroids are indicated in endobronchial TB. If endobronchial TB is giving rise to a large amount of emphysema, it's leading to air trapping, which is causing tachypnea, then you want to use steroids in these situations. Some people have even gone ahead and did an emergency bronchoscopy and removed the caesium, which is blocking, to get the patency, because these children really can get very sick. Because if you still see the CT, if you can go back to the CT scan. Interestingly, the area of the lung which is hyperinflated is also the least diseased area. So if I am able to get this better ventilated, then and as you can see the cross herniation of the lung to the opposite side, also in front of the heart, it is crossing the vertebral column in the back. So that is, all of this was there on the X-ray also. So these are the situations where there is a possibility, there is a possible role of using steroids along.
So all this is related to this extent of luminal compromise, which will manifest as these hyperinflations and collapses.
Yeah.
Thank you, Dr. Virendra sir. My question for both the cases would be that such patients, when they report to the field for the first time to the medical officer of a dispensary, what are the things that they should keep in mind, the medical officer, the district TB officers? What are the things that they look into? What are the red flags that should alarm them to refer these patients to higher hospitals?
So one most important thing is that initial presentation of a congenital TB may not be very sinister. They gradually become sick. So they may just present like, a child having cough, or a child having tachypnea, or a child having fever. So what is most important is, if you know the mother is infected, a detailed examination of the newborn by the person who has the skill, be the medical officer, be it a pediatrician, should be done. A hepatosplenomegaly at that point of time will forewarn you even before there are other symptoms. A child who is newborn, if he is coughing, there is a serious problem. Close contact as a mother who has been on treatment for TB in the recent past, last 1 or 2 months or 3 months or 6 months, she is more likely to have a congenital. Or closer the treatment was started to the delivery, more are the chances that it could even be perinatal, because then the mother is positive and still she's coughing out viable bacteria, and the newborn gets it very quickly. So contact survey, a proper symptom screen of all age group children who are in direct contact with a smear positive case is mandatory, more so for an infant. So that's the first important take home message which is there in this second case which we have seen. Whether it is perinatal or congenital is something we can split our hair on, but as Dr. Kamal very rightly mentioned, is more of an academic exercise, does not have an impact on the child. The second case was, the first case was on disseminated BCG. Again, if you are the medical officer in charge in the periphery and you have given BCG to a child or has been given by an ASHA worker or ANM in the field, and this child comes back to you with a lymph node on the same side and it is higher up, this may be BCGiosis. But if it is, there is contralateral lymphadenopathy, or this child is not thriving well, or this child is having any constitutional symptoms or organomegaly, this is a child who may have disseminated BCGiosis. Remember, in our milieu, HIV co-infection is a commoner cause of disseminated BCGiosis than the disease which was presented today. That is very rare. There are a handful of cases. So it doesn't matter. You do not have to investigate every patient for MSMD. But remember, this could also be any other immune suppressive disease, particularly a severe HIV. So if the mother was an HIV positive mother, then remember disseminated BCGiosis could be because the child was also getting infected. If this mother was not on any ART. We see less of these patients now because our ART criteria now are much more relaxed, and now there are more patients on ART therapy. Earlier, when it was driven by the CD4 count and duration, the ART was not received as much by as well by the mother and the child. So now we see less of dissemination, but that remains one of the confounders, one of the competitors here. Thank you.
Thank you, sir. There's one more question, like on the prophylaxis to these patients. Children born to the TB patients, mothers are to PTB positive, sputum positive. Can you just briefly explain us about the prophylaxis? Short, like if we consider them and when to not consider and when to consider.
So, madam, when we are considering prophylaxis as an option, the most important thing is to rule out a disease, because if there is any chance that there is disease, then this is going to be a blunder that we start a prophylactic therapy in such a child. So when you have such a child where the chances of the disease being are very high, then we should an effort should be made, a full-blown effort to rule out any chance of a disease, because otherwise it will be counterproductive. If we are very sure that this is not a disease, only then it should be considered. But this is in such a child to start prophylaxis also, it will not be easy until unless you are very, very sure as a clinician, and it will be a clinical decision.
So often you would also require an X-ray in these patients because the chest auscultation is not necessarily always contributory. In fact, you get more answers by tachypnea than otherwise. But this is one area where a chest X-ray may be useful. But remember, interpretation of those X-rays is also a challenge because they have thymus, superior mediastinal widening because of a normal thymus or an expiratory film. Be as it may, I would even go for an X-ray in a newborn or a child born to a mother with TB before I embark upon giving them TB preventive therapy.
Thank you, sir. Any more questions from the audience? There is a post-test link has been shared in your chat box and on the registered email IDs also. Please attempt that before leaving the clinic. So as we do not have any further questions from the audiences and neither in the chat box, and this clinic. Okay, so there is a question just appeared in the chat box. Does BCG adenitis needs treatment? I think we can.
So if it is BCG adenitis and you do not have any evidence of dissemination, then we know it is a localized disease and it has to be managed accordingly. So what we would suggest is that it would, of course, not require any kind of drugs or chemotherapy in any form for this particular thing. But because it's a local swelling which is increasing, which is bothersome to the parents, what we would suggest is that if the lymph node is big enough and there is any liquefaction or you can feel fluctuation, then a simple aspiration with a thick bore needle alone will reduce the risk of it rupturing on its own and leaving a bad scar. So the point is that it will take its own time to settle down. But if it is big, it is the collection is fluctuant, then a needle aspirate is something that you can offer. But otherwise, no drugs are to be given for BCG adenitis, which is a local disease.
Okay, sir, there's one more question in the chat box. Role of TB gold in the newborns.
Role of?
Role of TB gold or quantiferon.
For what purpose?
For the diagnosis of TB in newborn baby.
No, newborn baby the hypersensitivity reaction will come much later. So I do not know whether you would have a positive IGRA so early. Anyway, that is only to look at infection, never to make a diagnosis of disease. So I'm not sure it will be very helpful.
Yes, thank you, sir. So with this we end. Yes, Dr. Anand.
If the TB adenitis material is the TB net confirmed in the TB net test, the MTB detected, then we have to treat the child, or otherwise we should not.
No, that is BCG. No, the CB net does not make a distinction between BCG and it is the same MTB complex. So it is a virulence has been attenuated, but its DNA has not changed except for maybe RD1 regional reference 1, which has gone. That is not what you are measuring on CBNAT. CBNAT, you are looking at the other DNA sequences to make a diagnosis. So therefore, M. bovis is part of MTB complex. It will come positive.
Thank you, Varinder sir.
It will also be Z smear positive. So do not be misled by anything. Sometimes it may appear red. It does not mean it is just an impending rupture. It does not make it suppurative. Remember, when it is fluctuation comes quite late. If it is tense large swelling, it is better to put in a needle. A lot of people feel that if you put in a needle into a lymph node which is tubercular or BCG, it will create a sinus. No, that if it ruptures, it will create more sinus. And often you would require repeated aspiration. You will aspirate, it will refill, and gradually you'll find that the pus is becoming thinning out. So it may require 2, 3, 4 times of different time aspiration every week or 10 days. And you have to forewarn the family that this may happen. And usually these children, when they have plain BCG adenitis, they're absolutely healthy. They have nothing else. That is the key point. And sometimes this lymph node may be seen as late as 6 months, because when it becomes large, then only the family is able to appreciate it is there, because you are not palpating the axilla of a small child. So often it gets missed.
Yes, sir. Thank you so much, sir. So with this, we end today's clinic, and thanks to the Dr. Amber's team for the wonderful 2 cases, which have generated quite an insight among the audience. And thanks to Dr. Varinder sir for the insightful discussions and for taking all the questions and explaining them in such a simpler way. And thanks to the team ECO. Thanks to Shifa, who has always been supporting us for conduct of these eco clinics. And the next eco session is on 15th of October. Will be from Mumbai. JJ Medical College, Mumbai will be presenting the next case in the eco clinic. Please attend the post-test link which has been shared in your in the chat box and your registered email ID, and do share your feedback of the clinic. Thank you so much.
Thank you.
Thank you.
Thank you.